SMS Janil Puthucheary.
So I thank members for their support of the bill as well as their various comments. If I may just address a few of their issues. Ms. Ng Ling Ling and Mr. Ip Hon Hueng asked about the administration of the approval framework for modes of service delivery, especially where healthcare services are becoming more complex. I'd point out that HACSA is designed to cover a wide scope of healthcare services, including those that have been mentioned by Mr. Yip. MOH takes a risk-based approach, and this means that we only license healthcare service providers and require them to comply with the relevant requirements if there are patient safety or welfare risks that we need to control through legislations. We want to guard against overdoing this and ensure that services remain affordable and accessible. One concrete example, we're reviewing whether to regulate community health screening services that may involve invasive procedures such as the drawing of blood, but may not be provided by a medical practitioner or dentist, bearing in mind the general aim of making such services not only more accessible and convenient, but also safe for patients. So we're closely monitoring the community screening landscape to identify newer models or other types of services where they may pose a higher patient safety and welfare risk, and then explore whether those need to be licensed. There were a number of questions on telemedicine-related requirements, including by Mr. Louis Ng. If I may address some of those issues, we had consulted with our various licensees and communicated these to them over the past few months. From a service provision standpoint, telemedicine or remote medical service providers must ensure that the service provided is done so in a proper, effective, and safe manner, similar to what you would expect in a medical service from a clinic. For example, they have to ensure the privacy and confidentiality of the medical consult, the integrity and security of patient health records, the timely escalation and referral. Providers will also need to make sure that their doctors using the remote modality are trained and competent to do so. Our prevailing professional codes, such as the Singapore Medical Council's Ethical Code and ethical guidelines, will continue to apply. Doctors offering telemedicine will thus need to meet both professional practice and clinical service standards, which will provide a more comprehensive protection for patients. This applies to all healthcare professionals, as Dr. Tanya Swam has reiterated. It's important that all healthcare professionals are ourselves aware of the need to actively self-regulate and participate with that process of self-regulation, including by complying with and reading the professional codes of conduct, as the ultimate objective is to ensure that patient safety and welfare are not compromised. There were some questions about healthcare service advertising. Mr. Yip had asked whether existing licensees and businesses that contain the restricted terms, national or Singapore, will be allowed to retain their name. I mentioned that they can continue to use these terms unless there's a change in the business name or a change in the licensee. We understand that there is some brand equity built up already, and rather than mandating that these licensees immediately remove these restricted terms, will allow them to continue. Mr. Yip also asked about the licensees with specialty names. They may continue to use those names that they already have, but if they provide or purport to provide services within that specialty, we may impose regulatory requirements on such licensees to employ or engage the relevant specialist. Otherwise, we will work with the licensee to amend their business name. Otherwise, they'll be giving the wrong impression to the public, and that would not be in the patient's interests. I agree with Mr. Yip about public education. It's important to complement our regulatory effort, especially around how the public engages with business names and advertising. We'll be publishing the intent and scope of these naming restrictions so that public can understand what is allowed, what is not allowed, and they can have an easily accessible reference. More public education effort is needed to enable patients to be discerning in their consumption of healthcare services. In line with overall efforts on media literacy, we encourage the public to help one another, and we ask for members of the House to also help within their communities in doing so. We will also continue to encourage the public to perform due diligence and exercise some degree of discretion before engaging the services of any healthcare provider. A list of licensees with the modes of service delivery and specified services they are approved to provide will be published. and also made accessible through Health Hub so that the public can check if the healthcare provider they wish to obtain services from has the necessary approvals to provide those services. And we hope that the public will also participate and report errant institutions through feedback channels, which we can then investigate and take the appropriate enforcement action. Mr. Louis Ng brought up some issues around healthcare service advertising that may mislead using visual imagery. I agree with Mr. Ng that this risk exists, and we have provided restrictions on the use of certain terms, not just in the licensee's names, but in the use of those terms within the logo. However, the extension of restrictions to the use of visual imagery completely may limit businesses' ability to create a brand, to distinguish themselves, and I think there is room to significantly overstep. One example I might provide for Mr. Ng's consideration is the use of the heart shape. I think it's quite commonly used in a variety of settings. I don't think anybody would say that it is exclusively the purview of cardiologists, especially if it's a simplified cartoon-shaped heart. So we do need to be quite careful not to prevent all advertising. We will investigate complaints, however, on a case-by-case basis. And the examples that he cited, if there is a non-licensed provider or someone purporting to treat when they should not be, and doing so through the use of visual imagery, we would suggest that these cases are reported. We'll look at the visual imagery, but we'll also take into consideration the overall content and intent of the advertisement before we decide on whether we take enforcement action. The intent is to make sure that those providing treatment and medical services are appropriately regulated for the safety of the public. Mr. Ng suggested banning the use of the term doctor outright for healthcare service advertising. We've tried to have a balanced approach. The title doctor is something that is afforded not only to medical doctors, so PhD holders will also have that title. And having the title of doctor as a medical doctor does not automatically mean that one is licensed, but one does have that title. So we are trying through our approach to achieve the right balance and make it clear that where you are advertising a healthcare service, the appropriate description is used, including the description of your qualification or lack thereof for the provision of medical or dental services. So we don't think it's tenable to restrict the title of doctor, prevent it completely in all healthcare service advertising, but we think having these mandatory disclosures is a more balanced approach. Ms. Ng had some questions on the co-location of non-licensable healthcare services, such as TCM practitioners, together with licensable healthcare services. We have prescribed a list of services that can be co-located without needing to seek prior approval, and this includes TCM acupuncture services and services provided by registered allied health professionals such as physiotherapists. Beyond this list, service providers who wish to co-locate their services must seek MOH's approval, and conditions will be imposed, including requirements to comply with for their advertising. In particular, the advertising mustn't result in the misperception by patients that the co-located non-licensable healthcare service is actually licensed by HACSA. Where an advert covers both the licensable healthcare service and the co-located non-licensable service, it is the HACSA licensee that is responsible for ensuring compliance with the healthcare services regulations for the entire advert. I would also like to address Dr. Tan Yaswam's concern. The amendments already cover misleading claims made by non-HACSA licensees, including beauty and wellness service providers. This means that any salon that purports to treat a medical condition will be in contravention of the law. We continue to encourage the public to exercise discretion, and if the public is aware of such misleading claims, please escalate this to the Ministry for further investigation. So members have asked about the safeguards in the regulatory process. Mr. Yip highlighted that healthcare institutions may not have sufficient turnaround time given the 14-day notice period being removed. I'd like to stress again that we are only removing the 14-day notice period for a class of licensees, such as all licensees that provide an acute hospital service, and only in situations where there is immediate or imminent harm to patient safety. And such a situation would have significant impact on our healthcare workers' safety and our public health safety as well. Members will remember exceptional circumstances that include the recent COVID-19 pandemic, and you can extend this through other public health emergencies that are conceivable, and we would need to be able to react to these in a relatively swift manner. Based on our experience in COVID-19, the licensees can indeed meet the requirements and can do so at a relatively short notice. I'd like to assure Mr. Yip, Mr. Ng, that the aim of this amendment is to provide the Ministry with the power to direct groups of licensees to take immediate action. The focus is on saving lives through the quick introduction of safety measures, and not on penalizing licensees for not being able to comply with the Ministry's direction despite their best efforts. Ms. Ng also asked if it was too onerous to place the burden of approvals on one authority. I'd like to reassure her that the Ministry of Health and the agencies that are part of the family, we have a number of experts, committees and appeal advisory committees that are part of our normal processes, and so when guidance is given by Director of Medical Services and decisions are made by Minister, it is informed by a wide group of experts, academics, practitioners and professionals from the associations and various bodies representing healthcare workers, including the Academy of Medicine, Singapore Medical Association, the Singapore Dental Association, the College of Family Physicians, and our various expert committees and appeals advisory boards. These are all very much part of our ongoing process, and that is not going to change with HACSA. There were a number of questions by Dr. Associate Professor James Lim. I would point out that several of his questions address healthcare manpower, the professional certification of individuals, pastoral support for doctors and healthcare workers who are burning out, the universities and medical schools, none of which is covered by this bill before the House. And I would suggest that he might want to either raise the appropriate PQs or take this up at an appropriate time. There are some issues that he raised that are indeed covered, and I'd like to just go through them. The first is on the issue of TCM practitioners and other complementary and alternative medical practitioners. They are not prohibited from advertising, from describing what they do. What they're prohibited from is purporting to treat and diagnose medical conditions. And so I just want to make sure that we have a clear understanding. The TCM practitioners themselves have their own professional board that regulates them, and so that is not something that under this legislation we require them to state their qualifications. Professor Lim also brought up the issue of the language around premises. The intent is not to constrain premises. The intent is to regulate the service provisions. And so in describing premises, we have tried to cover indeed as many possible premises and models of service delivery. And so the intent is to look at the service and then specify and agree with the licensee how they will provide that service. And so hence, we do need the language to cover the various possibilities of how and where a service will be provided. I hope that addresses Professor Lim's query about why we have the language around permanent versus non-permanent versus conveyancing within the bill. Indeed, the point he brought up around international providers around virtual teleconsultations is important. We can't regulate what people have access to through the internet, but we do want to educate members of the public to be discerning about where they get their healthcare information from, and ideally they should get it from an identified, locally registered, licensed healthcare providers. If they do get information online from healthcare providers overseas, that is not something that this bill is going to be able to regulate. However, if that advice then requires them to have prescribed medication, consume medication, treatments and services and interventions, those are controlled by a variety of legislation and regulatory frameworks, and that is where we can perhaps assure more patient safety. But ultimately, the main thing is that when people look for information, they should be doing so ideally from a licensed, locally registered healthcare provider. I think I have addressed the various points. He also brought up the issue of midwifery professionals and nursing professionals. This bill does not regulate any of those. This bill is a bill to regulate the provision of services. It is not a bill to regulate the professional certification of individuals, and there are other legislation and regulation for that. So in conclusion, this bill introduces changes to future-proof our regulatory framework for agility, to enhance the operational efficiency and clarity, as well as strengthen safeguards for patient safety and welfare, to ensure our regulatory regime remains robust, agile, and responsive to provide better healthcare services to our population in Singapore. I thank members for the support of the bill, and I'd also like to take the opportunity to thank our licensees, healthcare professionals, professional associations, and members of the public who've contributed throughout our stakeholder consultation exercises, including virtual sessions which have involved more than 1,000 attendees, helping with ideas and suggestions to jointly improve the healthcare services regulatory framework. Mr. Speaker, I beg to move.
Are there any clarifications? Ms. Ng Ling Ling?
Thank you, Mr. Speaker. I just have one clarification for the SMS of Health. On the comment that MOH will take a risk-based approach and impose a regulation mainly when there are patient safety risks especially, some GPs in my constituency has asked, in preparation for Healthier SG, to the best intent, they wonder whether vaccinations such as flu vaccine that is in the national vaccination recommendation is allowed to be done in community clubs where the footfall is higher, where there are more natural flow and there are grassroots leaders who can, share the benefit of being vaccinated. But whether that is actually our premise and whether that can they claim the subsidies for flu vaccination. So just wanted to ask, are they supposed, after HATSA Amendment Bill has been implemented, to actually formally ask MOH before they do?
So I thank Ms. Ng for her question. If the issue is the subsidies for vaccination, I think that's beyond the scope of this bill, and I'd encourage her to file a parliamentary question or bring it up at an appropriate point in time. If the question is about could GPs perform vaccinations in the community centers and other locations, it is precisely this sort of flexibility that this bill now provides. The specifics would depend on which GP, which vaccination, and which community center, and so there would have to be an application made to MOH for approval. Thank you, sir.
Question is that the bill be now read a second time. As many as of the opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it.
Healthcare Services Amendment Bill.
Committee stage, what day?
Now, sir, I beg to move that Parliament will immediately resolve itself into a committee on the bill.
Question is that Parliament will immediately resolve itself into a committee on the bill. As many as are of the opinion say aye. Aye. To the contrary, say no. I think the ayes have it. The ayes have it. The question is that clauses 1 to 29 stand part of the bill. As many as are of that opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it. Bill to be reported. Minister for Health.
Mr. Speaker, I beg to report that the bill has been considered in committee and agreed to without amendment.
Third reading, what day?
Now, sir, I beg to move that the bill be now read a third time.
Question is that the bill be now read a third time. As many as are of that opinion say aye.
Aye.
To the contrary, say no. I think the ayes have it. The ayes have it.
Healthcare Services Amendment Bill.